This is ASAP Pathway. Welcome, friends. Welcome back to another episode of the ASAP Pathway podcast. I'm your host today, Dr. Stacy, and my partner, Dr. Tracey, is here today. I get excited. Yay, when she's here. Really excited. I say that a lot, but I mean, I'm so honored to be able to have conversations with the people that really honor us, with, joining. They're busy, they have a lot going on. And so I'm just so happy that tonight we have Dr. George Mandelaris, and he's a busy, busy, amazing practitioner. Welcome, George.
Thank you. Thank you. Thanks for having me.
Well, thanks for coming because I know
Yeah.
you just got done seeing patients, and I appreciate you squeezing this into your life. But I think what you're doing is very
Yeah.
important. And so I'd love to, educate the world on what you're doing and how people can learn more about you. And really excited about what's coming with the next Winds of Change, which you're going to be at as well. So I
Yeah.
would like to do an introduction. I'm going to read a shorter bio of you so we can jump in and get to the juicy
Sure.
parts here. I got to put my readers on, everybody, because cannot see without these readers. So
Welcome to the family.
I know. Dr. Mandelaris attended the University of Michigan from undergraduate all the way through dental school. He completed a postgraduate residency program at the University of Louisville School of Dentistry, where he obtained a certificate in the specialty of periodontology, as well as a Master of Science degree in oral biology. He is a diplomate of the American Board of Periodontology and a fellow in the American and International College of Dentists, the Academy of Osseointegration, as well as the Pierre Fauchard Academy. He is a two-time recipient of the American Academy of Periodontology's Clinical Research Award. Nationally recognized expert, he was appointed by the AAP to co-chair the first ever Best Evidence Consensus Workshop on the use of CBCT imaging in periodontics, as well as co-author the Academy's guidelines. In 2018, he was recognized with the American Academy of Periodontology Special Citation Award. He is the 2018 recipient of the Saul Schluger Memorial Award for Clinical Excellence in Diagnosis and Treatment Planning. He currently serves on the American Academy of Periodontology Board of Trustees and has served as a past president of the Illinois Society of Periodontists. He is in private practice in Oak Brook Terrace and Glenview, Illinois, where he limits his practice to periodontics, dental implant, and dentoalveolar bone surgery. Yay, welcome, George.
Yay. 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 Thank you. That's very nice. That's unfortunately a historical, it's all past performance. And you know, we have to be good today and tomorrow, not yesterday.
But it
Which all that
builds,
is
it
about.
builds. You got to have a yesterday of pretty good to be where you're at today too. So that's
Yeah.
nothing to shake a stick at. That's amazing. So Tracey and I were talking earlier about how you're doing all these exceptional things, but we're also trying to educate our fellow colleagues on new things in airway and sleep and surgery and orthodontics, TMJ, and the Winds of Change, which was started by doctors Reza Movahed and Maz Moshiri. The inaugural year was 2 years ago, and every year it's getting bigger and bigger. So the third year, so the last 2 years have been in St. Louis, and the next year is going to be this upcoming third year is going to be in Chicago. So in your neck of the woods. And I was hoping you could kind of tell us a little bit about what's
Yeah.
like this, why you're so excited. I'm excited. Tracey's excited. I know you guys are building the curriculum and it's just it keeps getting better and better. What makes this different?
I think a lot of it is the content that people want to hear and learn. And it's hard to get to get that in a typical like American Academy of Periodontology meeting, American Association of Orthodontists meeting, and an AMIS meeting, because they all kind of slant to what that specialty does and kind of how they view things. So this is pretty unique because you have so many people from so many different backgrounds contributing to basically, develop a new pathway or paradigm for our profession. And it's some of the very best people out there that have the biggest hearts, and they're really all doing it for the right reason, which is not to showboat who they are and kind of like be on a podium, but really share knowledge and to be in a collaborative environment with other professionals to elevate what we can do as dental medicine providers. And that's what I'm really excited about. The other thing that's super exciting is a very unique course because it's not just made up of lectures of people with different specialties and disciplines, but basically it's going to be there's going to be a cadaver course, and so I'll be showing like how do we do corticotomy surgery. Dr. Movahead is going to be showing how do we do like an MMA surgery, total joints, and genioplasty. Dr. Hutz is going to be showing, how is hypoglossal nerve stimulation done. So people will actually be able to see, like, to the best of our abilities, but we'll be able to see like how something like this is carried out. What do these procedures actually like look like?
Right, because there's a lot of
Obviously
histories
patients that can't talk
surrounding.
back, but
Yeah,
still, but I think that's a very unique perspective because a lot of people have never seen how corticotomy surgery is done. A lot of people have
yeah.
never seen how do you do a Lefort down fracture? What does that look like? And they'll be able to they'll be able to understand it better. The more people can understand, the better they can communicate with their patients when their diagnosis and treatment plan is right.
So
And the more
George,
confidence they'll have in like, that this is something the patient needs.
George, explain to our listeners what corticotomies are.
Sure.
Because I think you're so unique in that you're a periodontist, and I remember when I started early on this journey developing my team. I wanted to grab a periodontist. And I remember there's two or three periodontists that I asked, and one of them said, Tracey, I don't even know what my role is. And that was obviously like 7, 8 years ago when
Yeah.
people were still trying to figure out where they belonged in airway dentistry. So if you can tell our readers what is corticotomy and why should a periodontist be a part of the airway team when
Yeah.
we're developing that
Oh,
space?
I mean, Tracy, I could have a whole podcast on this.
I know, I
I
know.
could have a whole podcast
But
on it. But
I
I think,
love that I love that you're doing like a full hands-on workshop on it now. I
yeah,
mean, like that's so much needed to
I,
the periodontal community.
so so first of all, I just absolutely love my passion is interdisciplinary dentistry. Part of it is I just love interacting and collaborating with, all the different team members and coming up with really the ideal plan for the patient. But I got started in this very, very early on, probably 18, 20 years ago, when my buddy Brian Vense said, you got to go down to Fayetteville and see what Rick Robley's doing because they're doing some really amazing things down there. And, when I started learning from Rick, I felt like, it became an evolution because initially it was like, how do we move teeth faster? And then which like was like the least of why we would even do this. But as things have evolved, I believe that this is the future of periodontics. I mean, I believe this is the future of the periodontal surgeon of tomorrow because there are so many unique things that happen as a part of this type of surgery. It involves aesthetic crown enhancement, so putting the dental gingival complex into the correct position. It involves, opening and closing very gingerly like a periodontist would. But then once that's all open and the dental gingival complex is in the right spot, now it's about kind of changing the mindset to become a little bit more oral surgery driven in that you have to kind of get in there and do your corticotomies, dental alveolar decortication, and particulate bone grafting so that it's truly meaningful for what we call, periodontal phenotype modification for the orthodontist. So what is a corticotomy? A corticotomy is basically kind of a cut, an interdental cut in the bone, and it penetrates within the marrow at least 3-4 millimeters. And then dental alveolar decortication. And so usually that's in between the teeth or interdental. And then we usually connect those interdental cuts apically at least 5 millimeters beyond the apex of the tooth so we don't sever pulpal blood supply. And then if a tooth is dehisced, obviously there's no need for dental alveolar decortication because there is no bone to decorticate. But if you have a shield in front of a tooth, you have probably a lot of cortical bone. Then you will be doing essentially dots. Will be creating decortication around the outer aspect of the tooth to create what's called a demineralized bone matrix. So after that injury has been made, we are kind of simulating essentially fracture healing. And this was actually discovered by an orthopedic surgeon at Henry Ford Hospital by the name of Dr. Frost. And he was studying fracture healing in animals. And what he found was that during fracture healing, it's very similar to like creating an osteotomy site for implants, where you upregulate this inflammatory cascade of events. But it produces this demineralized bone matrix for about a 3 to 4 month period of time. And this is basically known as a regional acceleratory phenomena. So think of it as you kind of creating this injury to create a demineralized bone matrix. And if you happen to have braces on some of these teeth at that point, or you have aligners set up, well, now the teeth move without all the mineral content. So thus the reduction in treatment time, the teeth move faster because they don't have all that mineral content to go through. So the pressure tension mechanics, isn't quite like what we learned in dental school. You have this very upregulated coupling mechanism that happens with osteoclastic activity, osteoblastic activity, but the tooth is kind of moving through this demineralized bone matrix that occurs for about 3 or 4 months. After 3 or 4 months, the bone then remineralizes to basically the same mineral content where we compared to where we started. And this has actually been shown histologically. This is one of the most important papers actually in the orthodontic literature. Won the Milo Hellman Award, and so that's kind of basically the purpose of a corticotomy. Now we do corticotomies all the time. We just don't know we don't know that. So for instance, if you're doing horizontal bone augmentation, right? You're basically creating perforations in the bone to create neovascularization. So the bone graft basically you're creating blood vessels coming out of the marrow to vascularize the bone graft. That's kind of something similar that to a corticotomy, because essentially when you put the particulate bone graft on the outer aspect of the teeth, that bone graft has to become a vascularized functional matrix. It ultimately has to become a living organ system that can respond to stress and strain and long-term like mechanotransduction as the tooth functions or as an implant functions, right? So we need to get blood vessels from within the bone marrow out into the graft so that it becomes ultimately vascularized and it becomes like this organ system, whether it is meant for an implant or it's this periodontal organ system now that is displaced and augmented because of orthodontic treatment.
Well, if I could interrupt.
Yeah.
So, okay, here you are, a periodontist, talking about this, and this is a very periodontal thing, but we don't hear this procedure being done very much with orthodontics. When would you, I mean, what is your goal? Getting more? So, who is a candidate for something like this? Someone going through orthodontics, orthopedics, expansion. What age would you particularly do something like this on somebody?
Okay, so we have a couple papers that are coming out in the International Journal of Periodontics and Restorative Dentistry, and I'm very proud to have been on them. One is the lead author is Ashley Hoders, an amazing perioprostodontist from Seattle, and Mariana Evans and Kevin Murphy. And so the paper, the two, part one and two, are on phenotype-driven treatment planning. And so basically the way we kind of are going to look at patients are, do you have a relatively thick gingival phenotype? If you put the probe in, can you kind of see the probe coming through or not? Second is, do you have keratinized tissue that's more or less than 2 millimeters? If you don't on either one, then you have like a thin soft tissue phenotype. So any kind of like buccal tooth movement is probably going to cause some periodontal demise to an extent. On the same token, we also that's clinical. If we look at the patient from an imaging standpoint, we are going to look at the bone morphotype. Does the patient have more or less than a millimeter of facial bone thickness? Um, if they have less than a millimeter, they're kind of categorized as being more like susceptible or perhaps deficient in terms of bone. And ultimately, to answer your question, it really depends on how are the teeth going to be moved. And in today's world, Stacy, we can't accept lip service anymore. We can't accept like, well, I'm just going to move the teeth and that it's just going to work. Okay, it just is how I do things. It's just everything's going to be fine. Today we have imaging technology. That imaging technology can be infused into simulation software programs, be it SureSmile or Align or some other whatever that you can actually see and understand the impact of tooth movement on the dental alveolar complex. So no longer should we be accepting, here's the crowns of the teeth that are crooked and here everything is aligned. And by the way, the gums come along for the ride and look at how great everything looks. Because that never that never happens like in reality. So having technology that allows us to understand what's happening to the foundation and not to say like everybody needs corticotomy and bone grafting surgery because everybody's a millimeter of bone is on average normal human anatomy, so everybody needs grafting. That's not what I'm saying. What I'm saying is we do need to say like, okay, well, what is the risk assessment of aligning the teeth in the way in which we want to align them? Are the roots kind of really kind of dehisced out of the bone compared to the interproximal bone? Because if it is, then we need to kind of get some bone morphotype change. If it's minimal, then okay, we know that the 3D tends to overestimate how much bone loss that we
Yeah.
see. We don't have to just graft everything, but we
Right.
do need to kind of take that into consideration with the soft tissue, with the patient, and say, okay, well, from a risk assessment standpoint, like, do we monitor? Do we get out ahead of this a little bit, or maybe do we consider, um, you know, consider reevaluating? I think for expansion cases, if you're going to do like a MARPE, generally the skeletal expansion is done first, and then we would do some corticotomy treatment if we want to improve the bone morphotype. But if you're going to expand somebody with a MARPE, the question is like, how are you going to coordinate the lower arch? It's either going to be through a distraction, symphyseal distraction, or you have to like move the teeth out there. I mean,
Right.
or you're going to leave them with a huge posterior, overjet, or you're going to tip the teeth or camouflage to an extent, which is, never really, I mean, I hate hearing this like, oh, well, nobody ever died from gingival recession. True, nobody ever died from gingival recession, but newsflash, we're dentists and we don't treat cancer and we're not ER doctors. So we shouldn't accept like mediocrity or something that would be really substandard as
Right.
like
Right.
as okay,
Right. And the
as
bottom
standard of
line
care.
is it's a compromise situation. I mean,
Right.
and patients should be aware what their options are. And so I'm listening to you basically, what it sounds like to me with the imaging options we have, CBCT technology, which obviously you've served on a lot of, we know
Yeah.
too much. We cannot put our heads in the sand
Right.
and say, I'm just going to blow the teeth out and put them where they need to
Right.
be because the imaging is showing us we're compromising periodontal health. I mean, that could compromise someone's quality of life, early tooth loss. You got, a recession, increased caries, cavity risk.
Yes.
Now you got a filling. Now you need a crown. Now you need another
Right.
crown. Well, now the tooth needs a root canal. Now it's gone. So
Right.
it's just this progression of when you see a recessed tooth at 30 or 40 years old. I mean, God willing, we have another 40, 50 years left. You want the tooth to be there and buried with that patient. Like
Yeah.
the goal is quality of life and keeping those teeth. And so it sounds like, there's a paper coming out that's going to go into kind of a screening, if you will, of kind of who might benefit from
Right.
this with orthodontic treatment. And so this
Let
paper
me,
will be released to periodontists, I'm assuming. What journal
yeah.
would this be coming
Yeah,
out?
it's the International Journal of Periodontics and Restorative Dentistry, and it'll be in the first and second issues of 2026. But let me make it simple. Let me make
Okay.
it
Oh,
simple for you. Like
awesome.
where your antennas need to go up, right? And I'm going to pick on you guys a little bit here, not because I'm trying to be a jerk, but I'm just going to pick on. So the first thing is just to kind of like, and Tracy will love this, is just look at the face, right? Just look at the face. Because if you have a patient who is a vertical grower and you have a high mandibular plane angle, I'm telling you right now, that is a very challenging orthodontic case. Why? Because those patients tend to start out with less bone around their teeth, and they generally end up with less bone post orthodontic treatment, just because of their craniofacial phenotype. They've grown very vertical, and the dental alveolar complex has stretched. The bone around the teeth is generally cortical, so that is probably a higher risk for root resorption. If you have a patient that has a low angle, like brachycephalic face, well, they're going to have probably a very thick crustal bone. That may be a little less risky. If you have a patient like me that's just kind of normal, not looking like Brad Pitt or something, just kind of a normal face, okay, so that risk is maybe more, in the middle of the road. But if you have a patient that is a long face, long lower face height patient, high mandibular plane angle, dolichocephalic, those are the patients to really put your antennas up and say, whoa, we need to look at this in more detail. These patients require more astute treatment planning, more of a team approach, because there's a lot more going on. The risk is higher with that type of patient. That's how, I mean, just to kind of put it simple, just look at the face and start, kind of putting in the boxes. Hey, this is gonna be a more challenging patient.
Well, this will be pushed out in a perio slash restorative style journal. So we're going to have a lot of periodontists saying, okay, great information. Now what? So how do
So,
periodontists, what are they going to do? Where can
yeah,
they go to get more information? Because this isn't being totally, I mean, is it being
no,
taught in many residencies?
no.
Okay.
It's not. And this is the thing. It's and this is why I started giving the courses in my like live surgery courses in the office, is because it's not being taught. And there's a lot of need out there for it. But it is also very difficult to disseminate like 25 years of everyday, like learning this stuff over many, many years. And
Yeah.
luckily having very, very important people that have come into my life at different time points and taught me things and been open to share information, as I've learned it, towards periodontics, towards guided bone regeneration, towards more advanced ridge reconstruction, and then orthodontic treatment, and then orthognathic surgery. So, starting with my partner, Dr. Rosenfeld, it was very early on implants, and we were looking at scans and everything just from just from looking like medical grade CT scans, to eventually learning, oh, geez, I need to really learn bone augmentation,
Yeah.
and learning this from like Isvan Urban and like how GBR can be done. And then learning from like Dan Spagnoli, who taught me how to do BMP and really more involved, significant GBR types of surgeries. And so an oral maxillofacial surgeon really kind of showing and being able to teach uninhibited, just, to a periodontist. And then learning from like Rob Relly and Reza Movahed and some of these really incredible oral maxillofacial surgeons, to understand what is it that they're seeing, what are the complications they're having, and how can I better understand what their needs are, and then to learn from like a Rick Robley and Drew McDonald and Maz Moshiri and people like that, to say, okay, here's the orthodontist, here's what the orthodontic surgeon needs, here's the problem, and the periodontist is kind of in the middle, that really is shut out and like is hidden more or less. But the problem is right in that dental alveolar component. Um, and I think that there's a great opportunity for us to contribute to these interdisciplinary treatment plans that historically, it's been the orthodontist and the oral surgeon. They just kind of take over, and you don't ever see the patient again until they have gingival recession, root resorption, all these other issues. And that's not everybody, but I think there's room here to elevate our game as a team, and to really do right by our patients by spending the time to plan them as a team.
Like, obviously we at ASAP, we have a definite focus on airway health and education and interventions and sleep as well. So, when you think airway, a lot of people don't immediately go, oh, got to get a periodontist on the team.
No.
And it needs to be that. It needs to be that. So it's exciting because I think, the next 5 years, like you said, it's going to be changing.
Yeah.
And
So,
but
so here's how things would happen, right? So I would see these patients, and they would all come in for one reason, and that reason was gingival recession, right? So they come in for recession. They have this, okay, Miller class 1, 2, 3. You're going to graft and connective tissue, whatever. But what happens if you step back and don't just take like a little 5 by 5 scan or a 10 by 10? You step back and you start looking at the face and look at the position of the joints and all these other things. How compensated are they? You start to see like, whoa, they have invariably some sort of dental facial disharmony, malocclusion, right? So if I'm just not so tunnel visioned, and if
Yep.
I'll take the time to actually think through, like their entire system, they're how can I put that patient in a position for stability and health if that's the way the patient wants to go, right? If they just want to do the graft, then I'm on board with that. But if I at least explain to them, hey, you're a class 2 disharmony, you have really proclined teeth, the graft may not be stable because your teeth have no facial bone and they're very proclined. All these tangential forces may compromise the longevity. And then we start to screen them for some of these airway. So it's just not like what the billboard signs make it out to be. It takes time, and I think what I have seen over my career is people really valuing. We've gotten to this pendulum swing where everything has to be tomorrow, everything's got to be done today, everything's got to be in a 1 hour consult. It doesn't, and the patients are smart about this, and they really appreciate taking the time and then saying, you know what, I don't have the answers right now. Let me kind of follow up with you in a week or two, and I can study all this data, and then I want to sit down with you and go over what your options are, which maybe you don't want to do anything, but maybe, let me build this bridge
Yeah.
of what dentistry really is and what you think it is, and how we can impact your healthcare.
I just did a podcast last week with Christian Leonhardt, and we talked about this very topic because I think it makes a lot of practitioners, when you ask a practitioner to step out of their paradigm, their typical model, they get nervous, the team gets nervous. And he said, it's interesting, I mean, he's in Germany. He said, I haven't lost patience because I take more time. I haven't lost patience because I'm my appointments are a little longer. And sometimes he said I've even had to go back to some patients and say, look, I know I did the treatment this way, but I'm asking you to let me try this a different way. And I think if you just humble yourself and you're authentic and you tell the patient, I don't have all the answers right now, but I want to try to get all the answers for you. Oh my gosh, that goes such a long way, George.
Yeah, yeah.
And I know Tracy had a great question on this topic too of collaboration.
No, I think I have to say, like, one of the great things about Seattle Study Club. So I've spoken at a lot of Seattle Study Club periodontal groups. And so it's interesting because, like, I feel like the periodontists in the Seattle Study Club, like, they get the whole interdisciplinary care. They really understand being part of the team. I think the key with interdisciplinary care is everyone has to understand the procedure, not necessarily know how to do it, because then we all have to be able to talk about it together. So I think from a restorative standpoint, like, whoever the patient sees first, that person guides them in the direction, talks about the procedure, but not really go in depth, and then talks about everyone's role, and then everyone comes together. I
Yeah.
think that's really the key in it. I mean, but George, I think when we think about the advancements in periodontics and airway, do I want to kind of talk about, like, where we started and why are we here, and if I'm not mistaken, like, I think what ended up happening in the last 10 years is we've become obsessed with transverse numbers.
Mm.
And I feel like the public is like, I need 40 millimeters in the maxilla, and no one talks about the face, the arch, like, like it's like taking my jaw and putting it in your face, and it's like we have to get back to like personalized care. I mean, I
Yeah.
have patients that are like, well, my therapist says like I'm not even close to having 40 millimeters. I said, you will never have 40 millimeters. It's like we have to get back to like home. I almost feel like there's too much information that the patient doesn't know how to process it, and
Yeah.
so when we talk about the problem and why we are here where we are, do you feel like this obsession has got us to being like, let's just move the teeth where we feel like they need to be, and now we're outside, and so now we have talking about like grafting, yeah,
Yeah, I'm not sure. I'm not sure why people are that are, involved in tooth movement, why they're afraid to talk about periodontal surgery. I think just historically because it's not, it's generally not part of the discussion when it comes to orthodontics, but because of imaging and their known regional anatomy limitations, it really has to be. Um, Getting back to the treatment planning, like Tracey, you made some really good points. Yes, historically with Seattle Study Club, it was always the periodontist kind of like, but
yeah,
in my view, we're teaching like 1990s, like how do you push and pull teeth? How do you like facial aesthetics, all great. But today it's really about structure, function, and behavior. Those are the three keys, right? It's
yeah,
about joint stabilization. And if you're not going to have, the periodontist kind of like understanding, hey, what is the condyle distracted? What is the normal joint space supposed to be?
yeah,
All these types of things. If we're the ringleaders of the interdisciplinary team, then we need to kind of act like it. We need to diagnose like it. And that invariably is going to mean getting an orthodontist on board and getting a maxillofacial surgeon on board. And like what can we do here? Um, yeah, I think with the expansion stuff, yeah, the issue that I have a little bit with expansion is I think it's transformed orthodontics. I think it's incredible what we can do for patients, but like, how are we measuring our results, right? Like, if somebody is expanding somebody non-surgically bone anchor expander for dental reasons, okay, great. But if you're expanding them for airway reasons, right? Like, when do you know when to stop?
yeah,
How are you measuring their nasal flow, their nasal resistance to know, hey, 38's fine, patient breathes fine, or 40, they need to go to 44, or what, like how are we measuring these things? Because I don't see anybody measuring this, or maybe very few people. Like, I'm aware of the four-phase rhinomanometry and things like that, but I think we kind of like, if you're going to take that responsibility for that purpose, for dental purpose, different. But if you're doing it
yeah.
for an airway nasal, then you gotta like measure it so that like this is where we started, this is kind of how we've improved, and these are, it's not like subjective anymore.
Yeah, 100%. Because I feel like that too. Like when I at my office, you have to have metrics. You have to have either sleep metrics, questionnaire,
Yeah,
HRPO, something, because like I mean, you have to know when to stop, like or
I
when you
just I think another thing is like gingival recession has been the barometer of like when there's a problem, right? We just move the teeth and like there's no recession, there's no problem. Well, like gingival recession in 2025 can no longer be the barometer of like when to stop moving teeth, or when is there a problem or is there not a problem, because we have in too much information to know, like there's better vehicles of assessing, metrics to use to determine other interventions that may be needed to support the therapy that somebody's providing. I mean, a perfect example is some of these ridiculous therapies that, kind of expand people out, they always have an acronym too,
Oh yeah.
nothing, I don't mean, but they always have some kind of like, but anyways, they just blow the teeth out, and now you have to kind of recover from that, and it's hard to recover. And you know what's most difficult with these patients is recovering their trust.
Mm.
And
yes,
recovering the patient's trust is like almost impossible.
Yeah.
And that is really something that, our profession has, we have earned that trust through generations of people, building on their shoulders. And we just can't take it for granted. It's really it's an honor, and it's like something that's been bestowed on us over the years and over the other generations, and we need to take it and move it forward.
Hmm.
Well said. And when you do lose that trust, ooh, that's tough. It's tough to get that back. And especially in the airway world, I mean, you see a lot of big inpatients. They've tried so much, and a lot has failed by the time they get to maybe a sleep dentist. Maybe they've tried CPAP, or they've tried a UPPP, they've tried a septoplasty with turbinate reduction, and they're still exhausted and they're still tired and they can't wear the CPAP, and now it won't work so you get a lot of patients that already come to you. They don't have a lot of trust to begin with,
Yeah,
especially in the airway world. By the
yeah,
time they get to us, they're like, all right, what are you going to do that's any different than anybody else? So we got to be very careful. So, like, we say this a lot in our ASAP community. You know, a lot of people are having to build, and you know this, George, and it's like you're having to build your community. This is not a common practice to have a kind of collaborative team like this. It should be, and I think it will be, but right now it isn't. So for the person listening right now, like they're really interested in this, they might have a surgeon on board. And they have an orthodontist and maybe an ENT, but they don't have that periodontist. We always say, hey, why don't you, next course you go to, ask your periodontist that you really have a great relationship with, and say, I'm going on this adventure here, this new journey. Um, I'd really like you along with me on this. Would you be willing to go to a course with me? And maybe we can do this together. Um, and I think Winds of Change would be a great
yeah,
start for somebody where you've got all of like you mentioned, all these amazing mentors, all these amazing teachers, and yes, they're all needed. But if you could find a meeting of the minds where you can see all of the needed professions, coming together in one place and seeing that collaboration. I think that's huge.
yeah. I mean that there's going to be no meeting like it, and we hope it will be one that will set the stage for many years to come. Something that everybody will always be excited to kind of come back for. Um, the periodontists are out there. There are so many of us that would love to be doing this stuff and would like just die to have our orthodontist say, "Hey, bring me, like I want you to kind of be involved in this plan. When do you think we need to do this or that?" But if the orthodontist would be open enough to kind of think about these things, if the oral surgeon will realize that we're not trying to take your implants, we're not trying to take your extractions. We're trying to do something that is really in the periodontal wheelhouse. Because at the end of the day, it is regeneration, it's periodontal regeneration, it's guided bone regeneration, it's everything it's aesthetic crown lengthening, it's functional crown lengthening. There's so many things about it that are in the periodontal wheelhouse, that I think we can contribute to the team and make life even easier for the rest of the team members. The periodontists are out there wanting to do this stuff. You just got to spend some time trying to find the right person who will spend the time and invest in themselves and invest in their team members, so that everybody can grow in the direction. And just may take you may have to kiss a few frogs before you find the
I say
prince,
that all the
kind of like
time. I say that
it
all the
just
time.
and just
Don't
kind of the way
You
the
can't
way it
back
is.
down. You can't back down just because you
No.
get a no from somebody.
Yeah.
So you got to
Yeah.
keep going. But
Yeah.
I love what, we were talking about earlier too, with, you know, how important the collaboration is. And, um, you know, I believe firmly in my experience, and I've been doing this a long time, which I can't believe I've been doing as long as I have, but I know it's like, I don't even want to say how long I've been doing this, but, um, you really, if you learn each other, you don't have to know how to do it yourself. Because in the beginning of all this, you just kind of feel like, I have to know how to do this, I have to know how to do that. Not to the point where you do it yourself, but having an understanding of how it works and screening and referring appropriately. And I mean, you're going to, I actually had a periodontist in town say this when I started learning how to do implants. I was so nervous to tell him. I thought he is going to be so
Yeah.
upset that I'm placing not, just your basic implants. And I told him, I said, "Oh, Justin, I just wanted you to know I took a guided implant course." And he goes, "I am so excited." And I said, "Oh, that is not what I thought you were going to say." And he goes, "Look," he goes, "I want to tell you why. When you learn how to do basic implants and you have a better understanding of implantology, you're actually going to refer to me more."
Yeah.
And I thought, huh, and he's right. And anybody I refer to him, it's a setup. Like they're doing it. They already are going to do it. So it is a beautiful thing because now you have an understanding and you have this beautiful continuity of care and
Yeah.
communication happening. And that is so important. You don't want your patient getting lost in the abyss of a referral.
Right.
So, I think going together, learning together, starting study clubs in your town or starting, groups and meetings or just, having coffee, and getting somebody to come to Winds of Change. So I know that, do you guys have an idea? When is it going to be? Is it December still?
No, it's February. It's the
It's
first weekend
February.
of February.
Okay.
Yeah. It's a
Okay.
three-day event. And
Oh yeah, the first year was December and then it
and
was,
there will be some myofunctional therapy there. So some people can sign up for like the lecture tracks, and the others can sign up for I think the lecture and the cadaver
I think it's
tracks.
is it 3 days with the cadaver labs and everything too?
Yeah.
Yes.
Yeah. It's February 5th and 7th.
And that is lecture. When is the cadaver? Is that the 8th?
Is it
Seventh.
the
Is
7th?
it
It's on a
5th, 6th,
Saturday,
and the
right?
7th? Okay.
Yeah. Yeah. I think it's Saturday. George, do we decide like is the cadaver a half day or is that a full day? Is it
That's
3
a
full
full day.
days?
It's
Three full
SFOT,
days.
it's MMA, it's hypoglossal nerve stimulation, and I think total
Mm,
joints. I think Reza may be doing that as well.
Uh,
So
This is
there's a lot
yeah.
there.
This is a great course for the entire team.
it is.
It's really to come together and be like, okay, I can do that. Can I do this? I mean, I'll say with my periodontist, so, uh, uh, oops, I don't know how I think I just, there you go. Uh, um, like, so we always say that people don't say no to Tracy because like I keep on like pestering them. So like my periodontist finally, like I would send him stuff and he's like, Tracy, you've been telling me for how many years now? Now I get it. And then he finally get it. So I would say tell our restorative doctors, you just, if you believe in what you are doing, and I think your team will support you. You just have to be able to communicate that to your team.
Yeah.
And I think that's the key there. Like, hey, like I need to do this, and obviously I'm not skilled in this. Can you do this for me? And so I think, George, how do you like imagine if you how would you like to be approached by a restorative doctor to like
Good
how
question.
what are good ways for us to communicate to a periodontist to ask them to join the team?
Um, well, I mean, I certainly think one way is to just to make the phone call and just to say, hey, this is really, this is kind of where I'm at. These are what my goals are. I'd really like to kind of, have a place where I can be mentored, where I can grow. Because honestly, the more you have somebody like that in your team, the more we're going to learn from you as well. So I mean, just think about like all the restorative things that are really needed.
Mhm.
Tracy, if you have your patient who has the airway problems, who needs MMA, but they have like the tooth proportions are off, right? So you now
Yep.
really they need the really, the intrinsic proportions of the teeth need to be put together properly so that, the orthodontic surgeon could just move everything correctly and not move them in the wrong spot because he couldn't really see where the teeth, or she couldn't see where the teeth were supposed to be. So you need that, what we call restorative leadership,
Mhm.
really kind of, driving everything, which is I mean, that's the hardest thing of everything really. But but I think just, just contacting your local periodontist or your oral surgeon or your orthodontist and say, look, like I really want to get a team here. Um, and you just are willing to kind of start the journey. But it does start with yourself because you have to kind of learn yourself, and you have to kind of like, be willing to uh, be vulnerable a little bit, and
Yeah.
Yes.
and just kind of like, you know get out there on a wing and try to, because I think when you start seeing like really what all this, like SFOT, what really all that really does really mean, it's not like restorative dentists could do that. There's a lot of good restorative dentists do great surgery. It just
Yeah.
takes a lot of time. Like, is that really profitable for you? Is that something like,
Right.
are you set up to do like, do you have dental anesthesiologists to do intubated GAs in your office? Do you have all the support that's needed? Do you know how to manage complications? You want to deal with all that, because once you start seeing like all the restorative that generally comes with many of these cases, I mean, that's a lot there too. And that's so we need people that are really like being able to be dedicated at their craft at the very highest level to contribute. And that's the kind of person you want to grow and develop, really, anyways. I think that's just my 2 cents.
Well, your two
But
Yeah.
cents matters. That's why we have you
that's
on
my
the.
2 cents. I don't know. That's my 2 cents. But I,
Oh, no,
I
I
really, I
understand
mean,
that.
I
That's
love, I
important.
love, I love, I love the interdisciplinary approach. I love, I just love collaborating with people and our colleagues. I love,
I
making impact with patients, and just, you know, it just, the friendships that you can develop with all this,
uh,
that really go beyond dentistry, is very meaningful. And I think that's something that sustains you, day
it
in and day
does.
out for many years.
I think you hit it on the head too. You said to be vulnerable, and if I've learned anything in this journey is humility, humility, and leave your ego at the door. And
Hmm.
because you have so many people, and we've watched this, Tracy and I, gosh, I can't even tell you how many times we've said this, like at dinner, we'll be at a course and you'll see people walking around and they're like saying they're the expert in this and the expert in that. And it's like, wow, that's really a bold thing to say. I mean,
Yeah,
because it's the practice of, dental medicine, and, we're all learning. And of course, there is definitely literature, and this isn't like guessing,
yeah,
but, you know, it's just be vulnerable and humble and know that, you know, we're not practicing like today, like we were years ago. And in a few years, we
yeah,
might not even be doing what we're teaching now, but um, it's just to stay open and just
yeah,
not be so rigid in your thought
yeah.
process,
Yeah, Stacy, one person doesn't know it all. I mean, no way. I mean,
Oh,
there's no way
Oh,
that like one person can know as much as four, right? And so,
right,
that's what
right.
and at
John
the end of
always
the
says.
day,
Not one of
that,
us is smarter than all of us.
yeah, that's really the patient is
Yeah.
what kind of benefits. And I think, look, patients with these issues too have been, treated with like bone grafts that have failed, and this that has failed, and this is kind of relapse, and all these redos that we seem to be becoming experts in. It's like, they don't want to know like how quickly you can like schedule them for something. They want to know like they're being taken care of. And you've gone through a Mayo Clinic model kind of process with them so that they understand, and you've really kind of like dotted all the I's and crossed all the T's to make sure that they are likely not going to have to deal with this again. So they can be in a situation where they don't have to think about their teeth again. They're healthy and they're sustainable. They have a sustainable situation for oral health for many years to come, to the best of our abilities today.
Right.
And it's just, that's the art and science of what we do. It's not black and white. But I
So,
think if you're vulnerable to your colleagues, but also your patient, to say, maybe I don't really know, I don't have a crystal ball, I don't know what the future is going to hold, but I'm going to put you in a situation that hopefully is going to be the most sustainable and the most predictable, and then we'll maintain and monitor. And I think if you just come from a place of, just honesty and integrity,
Mm.
people see through that. You're not trying to sell
yeah.
something. This is, and then they can decide what they want to do
Right.
based on their
Right.
position in life and what their goals are.
George, did you say that you think that you're coming out with like a screening tool for um, GPs and orthodontists on like
Oh,
when we are doing our assessment of a movement of teeth and evaluating the biotype,
yeah.
that we'll have a good screening on like the danger zone of teeth movement, something like that, something simple because everyone's moving teeth.
Yes.
GPs and orthos. Like, is there a screening tool that that that's available right now that we can say like, hey, we shouldn't move in this biotype yet, or is that coming?
Well, again, like so part one of this phenotype-driven treatment planning essentially is kind of like a risk assessment. And so we
Yeah, I
categorize
like that.
patients as being like, you have a phenotype that's intact, you have a phenotype that is susceptible, or you have a phenotype that is deficient. And so ultimately, like once you, and that is dependent on like gingival parameters, like thickness of keratinized
Yep.
tissue, and then width of keratinized tissue, and then bone morphotype, like thicker, thinner than so a millimeter of facial bone. So, but what you do with that, like initial clinical presentation of the patient, that I mean, really depends on like whatever you're going to do with that. Then you decide like I do nothing and I monitor, or I do
Yeah.
maybe some soft tissue embellishment, alloderm or connective tissue graft or pre-gingival graft, or maybe I do bone modification. So depending on where is that patient headed, is that patient headed for a reses kind of operatory with like, big
Yeah.
MMA and all this and Maz's chair with all this expansion and all. So this depends on like where the treatment plan is headed. So here's where the patient starts. And I think, once you kind of can dance around where that patient is headed, then you can apply the known risks or the situation to make the best treatment selection for that patient.
I think that'd be great because right now we don't have a risk assessment for tooth movement.
Mm-mm.
Yeah.
I
No.
think that'd be great when that comes out. Yeah.
Yeah, but like anything, it's just like, the devil's in the details. Once
Yeah.
you got to get into the planning and all that
Yes.
other stuff, and then you kind of decide, okay, well, I mean,
Agreed.
because sometimes, the human body is pretty remarkable in terms of its reparative capacity, and things actually end up better than when you thought, or, maybe it kind of changed course and you thought, boy, things got a little bit more stressed than we thought it would be. So maybe we need to pivot a little bit so we can get to the same outcome that we had originally planned on.
Well, again, we could have an
Uh,
entire podcast again and touch on stuff we didn't even get to.
Oh, it's gonna be that whole 3 day lecture.
yeah,
Yeah, you guys need to come to Winds of Change 2026
right,
February.
right.
And
George,
we'll,
when's your fall course? You have a fall course coming
Yeah,
up?
so I have a
First
fall
birth.
course that's so it's not meant to be like 300 people. It's only meant to be like 10 to 20 people, but it's a surgical mentorship course. It's a live surgery course. So we do a full day of kind of the didactic stuff of the biology behind SFOT, show all like my God of growing pains over the last 20 years of the problems, like how I used to look at things and then how I'm looking at it now and all the problems along the way because I've followed so many of these patients for years and I've shown like this is look what I did 10 years ago. I mean, this ended up as garbage now. Now, we would look at it differently today. So it's all these kind of building blocks and then we usually have a guest speaker over dinner and then we have a live surgery the next day, which is actually kind of, doing an upper lower jaw surgery and people can actually kind of see over the shoulder or through a video camera that we have in the OR, and you can stream it so
Yeah,
we
I
can
gotta
see it,
go.
and then so I'm just trying to be honest and show like I don't have all the answers. If I don't have the answers, I'll tell you, and I just like I don't know, but I'll try to get the answer, and
well,
and
regarding your course, and when does
it's
registration
it's
close?
it's November 7th and 8th in Glenview at our Glenview location in just a little bit north of O'Hare. It's maybe like 15 minutes. And there's a couple hotels really very close. But I guess it closes November 6th unless it fills up before
Okay.
then.
Well, I'll have to get the link for you to put it in this podcast. So
Oh, yeah,
I'll
sure.
reach, if you
Yeah,
haven't
sure.
given it to me ahead of
Yeah.
time, I
But
will get
we
it
did
to
the
you.
first one in April, and it was like we had like 10, 20, 12 people there, and I was really amazed with the feedback. I mean, people were really like, and
Yeah.
I hope it gave people like the confidence to say like, I'm going to like, I don't need to necessarily do a double jaw the first day back, but I'm going to start. I'm going to think about this. I'm going to start planning this, and I'm going to get I have the confidence now to kind of do this. And the other thing is, it's just the relationship build that, the course doesn't necessarily have to end on November 8th. I mean, we've built a relationship with people, and if I can help them beyond that, I'm certainly going to do that. But I just want to try to share as much as I can. I enjoy teaching, and I enjoy sharing, and I enjoy learning from other people, because there's a lot of people in their room that have other ideas and other thoughts, and
Right.
probably can make me
Yeah.
better. So a little selfishly, it's like,
Oh, heck yes.
kind of nice to learn from other people, even though they think they're coming to learn
Yes.
from me.
Well, and
So
it brings me to my next. I was going to do a little ASAP course bookkeeping,
sure.
because we selfishly do the same thing. We have amazing, lecturers and clinicians that teach for us, and we too are learning as well. And even in this podcast, I love it because I always learn something myself. I selfishly will write down things I want to do when I get back, or who I want to collaborate with. So I'm going to just go through really quick and the links will be in the podcast for some upcoming ASAP courses. And then I'm going to get to your 3 questions you're not getting out of your 3 awkward questions. Actually, I'm easy
Oh,
on you.
okay.
George, I was easy on you. The past couple of people have had some doozies, and I try to keep it easy on you.
Okay. All right.
So the immersion course, the ASAP immersion course, actually our registration just ended last week for this coming immersion. This is an online platform to dive in, and we break it up into 4 modules. We have registration opening up in August for the next round, which will be September, October, November, and December. So you can get on. I'll have a link for the ASAP immersion. Also, we have coming up skeletal expander pathway. We have a course number 2 is coming in September 13th and 14th. This is taught by Dr. Ilya Lipkin. And the registration,
Awesome.
I love him.
And it's only going to be about aligners. This time we're only talking about
all aligners. So this is great
Yeah.
finishing. And the last day to register is July 1st. Again, the course is September 13th through 14th, and I have the link. Then we have early ortho intervention. The part 2, we already had part 1 just last month. Part 2 is October 9th through 11th. The registration ends for that. This is with Dr. Courtney Levine. She's amazing. And this registration ends August 1st. The last course of the year, we have Advanced Frenectomy Clinical and Practical Solutions, taught by Dr. Tracey Tran. This will be September 27th. It's a 1-day course. Again, registration ends August 1st. We're going to have the links in the podcast for that. And here we go, George. 3 questions. It's summertime and you're grilling. Do you want hot dogs or hamburgers?
Hamburgers.
Hamburger guy.
Yeah.
Are you meat? You're a burger girl?
Yeah.
Your burger?
And I have to have an egg on it.
Oh, always?
I love eggs on my burgers.
Is it like a fried egg or sunny side up?
Fried egg.
I like a fried egg, but I don't want to bite into a sunny side up egg on my burger.
Yeah, no, I like it kind of runny.
Oh gosh, then that's not a fried egg. That's a sunny side up. Okay. Number 2, you're at the beach. Are you in the water or are you under an umbrella hiding from
I'm under umbrella.
So am I.
I'm under umbrella.
I was kind of guessing.
I'll tell you what, though, my 2 daughters are always going to bet that they're going to get more tan than dad. And you know what? I'm under the umbrella, and guess who wins? Every time. Not even close. Not even close. And I don't even have any sun.
Right. And you get more tan.
I crush them.
Tracy, I know your answer. You're in the water.
I'm in the water.
She's in the water. Okay. What is your favorite summer destination?
Greece.
Ooh.
Greece.
How often do you go? How often do you get to go?
Probably the last couple of years of every summer. Yeah, we've gone every summer.
How beautiful. I have heard one of the most beautiful places on earth is Greece.
No question. Yeah.
Well, thanks for joining us, George.
Am I being psychoanalyzed with this?
Kind of. I've already kind of figured out who you are.
Okay. It's like, wait a minute, maybe I should have answered a different question.
I'm gonna give you some sunscreen.
Yeah.
Well, I appreciate you coming on with us, George. And for the
Thank you,
person,
George.
thanks for the person.
Thanks, guys.
Absolutely. If
Thanks
you
for having me, and thanks for all you're doing to help create awareness and move
absolutely.
the needle for our
Well,
profession
we're
in
all doing it
dentistry.
together. We're all doing
Yeah,
it together.
yeah.
And, if you're listening and you're on the fence, just start reaching out to some people, like kiss a few frogs and bring your colleague with you to some of these
Yeah.
meetings. And it's a lot of fun on the journey. Thanks everybody for joining us, and we will see you all next time.
Thanks.
Bye.
Okay.
Bye.
Bye.
This podcast would not be possible without the inspiration of my dad, Dan Becker, and creative direction and editing from the talented Jason Becker, Benjamin, and Judah Walker. To stay connected and keep the conversation going, be sure to subscribe to our podcast and visit our website at asappathway.com. And remember, the information in this podcast is for educational purposes only. It's not intended to be used as medical advice or replace your healthcare provider's diagnosis or recommendations.